So thank you for having me at your course in Erbil. I remember being there a few years ago. It's a beautiful place, and I'm very sorry I cannot be there in person, but I'm also happy that technology allows me to share with you some of my thoughts and experiences on minimally invasive surgery electronically, and I hope everything works out so you can see the presentation and hear me. And I wish you a successful course. And again, my apologies for not being able to be there in person. So we're going to get started, and we're going to talk about the 6 T's of Spinal MIS. What are the 6 T's? We'll get there in a few moments. What is MIS spine surgery? Now, as some of you may know, we started a MIS task force within AOSpine, and the goal here is really to develop educational material that can be used around the world by surgeons interested in minimally invasive spinal surgery. And one of the first tasks that we tried to address was a definition of what minimally invasive spinal surgery really is or should be. And what we came up with is really based on our experience, based on looking at the literature, and is summarized in this sentence here. So it's a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function and striving for better outcomes than traditional, usually open surgical techniques. So that is really what we consider MIS and what the goals of MIS spinal surgery should be. How did this all evolve over the years? If you look at the different types of pathologies that we treat as spine surgeons, looking at different complexities, starting with low complexity and going to higher, more significant complexity. The lowest complexity is probably herniated disc, especially in the lumbar spine. And then that goes to severe deformity correction procedures. All of these can be treated with obviously traditional open surgery, and sometimes very successfully so. And all of these now have been translated into some type of minimally invasive or less invasive procedure. The low complexity procedures obviously take advantage of the microscope and the endoscope. But then we have, translumbar, oblique, anterior approaches that are less invasive, that allow us to address some of the more complex deformity cases. Now, however, where's really the benefit? Where's the sweet spot for MIS today? And I think that you can understand really the benefit of MIS if you look at the complexity versus the invasiveness of some of the procedures that we do in spinal surgery. Again, the complexity starting with a very low complexity operation like a disc herniation, going all the way up to complex deformity surgery. And if you look at open traditional surgery, if you look at low complexity procedures, even when you do these with open traditional surgery, and we all know that they're not very invasive, and these patients do very well. They go home very quickly and recover. But then it gets steep very quickly. And in terms of invasiveness, even if you have an open laminectomy, multi-level laminectomy, a simple fusion operation, those are already pretty invasive if you look at parameters such as infection, blood loss, length of stay, and so forth. Now with MIS surgery, what you really do is you dampen this curve. The low complexity operations are still going to be less invasive, and these patients don't necessarily do much better than with open surgery. But really the sweet spot is kind of in between the very low complex surgeries and the high complex deformity correction operations, which even with minimally invasive surgery are actually relatively invasive. So the sweet spot for MIS, the benefit zone, are really the operations that deal with 1, 2, 3 level lumbar stenosis, 1, 2, 3 level lumbar fusion or thoracolumbar fusion cases, and also obviously in the cervical spine. So that is really the benefit zone. Now don't forget though, if you look at the whole field of spinal surgery, This makes up the majority of things that we do as spinal surgeons. So there's a real role and there's a real importance that goes along with MIS surgery. And this is really currently the kind of like the status. And this is the reason why I think that spinal surgeons should try to look at MIS as a way to really cover a large portion of what they do and make those operations less invasive, associated with less blood loss, less infection rates, and so forth. So that's really then where we start thinking, well, MIS, we have a definition, but what does that really mean in terms of principles? What does it entail in detail? The first and the most important thing, and unfortunately also the thing that we rarely talk about, is target, meaning patient selection. Finding the right operation for the right patient. And I always tell my residents, the least invasive spine surgery is the operation that you don't do because the patient doesn't need it. So that's the number one MIS surgery. And that's obviously an exaggeration for my part, but really what we're trying to say here is you have to pick the right operation for the right patient. And that's the challenge. That requires an adequate physical examination, testing of the patient, and you have to be familiar with a lot of surgical techniques and technologies to then be able to really tailor your operation to the patient's real problem. And then what we all know about and what we're all really into is playing with tools and technology, and that's where MIS becomes so interesting because it gives you access technologies, navigation, robotic surgery, endoscopic surgery, and so on. Techniques, very difficult to pick up unless you have a good teacher, you come from a good training program, you do cadaver courses and so forth. And we're going to talk in this presentation a lot about techniques. Teaching and training, whether you're teaching and training yourself or you're teaching and training somebody else, very important in any type of surgical specialty. Finally, testing or research. Whatever we do, we want to collect data. If you start doing MIS surgery, you want to collect your outcome data and you want to compare that to what people have done in the past and are currently doing. And maybe you even want to publish and improve the field of MIS surgery with your work. And again, something that we rarely talk about, talent. And I think we don't know enough really about what talent really means. And are there surgeons that may be more talented for open surgery than for MIS surgery? This becomes very important, especially if you look at teaching and training and how to convey those surgical skills to surgeons at the beginning of their learning curve. And so let's talk just briefly about target. I just want to show you this example. This is a patient who came to me about a year ago from Europe, and she had a beautifully done, the least invasive fusion operation that I've ever seen, with tiny little incisions. And they did a vertebroplasty here, an augmentation. They put a nice cage in. She had a great fusion here at L4-5, and that's the CT scan. But she still had a lot of pain. She had neurogenic claudication when I saw her, and this operation had just been done maybe a year or so before. And we got an MRI scan, and the MRI scan showed severe lumbar stenosis. So I was really shocked to see this because they did an amazing operation. I don't know why she needed a fusion, but they totally missed the fact that she had lumbar stenosis. So this patient could have been treated just with a minimally invasive decompression. So whoever did this, I think they probably totally missed the boat and did the wrong operation for the wrong pathology. And that's the target problem. That's a target problem. So you can be an excellent technician, but you got to diagnose, you got to examine the patient, and you got to correlate the symptoms with the patient's imaging findings and with your technical abilities. Tools and technology, we're going to talk a lot about this. This entails the access technology, tubular specular retractors. We can access virtually any part of the spine now in a less invasive way. The microscope that we frequently use, some surgeons use the endoscope, navigation technologies, implants, expandable cages, cannulated pedicle screws, using the drill. No lasers, okay? We use lasers, but not for spine. So techniques, and this is where it really becomes interesting. And I want to focus on 3 technique principles. And these are technique principles that if you deal with MIS spinal surgery, they always come up in one way or the other, in the lumbar spine and the cervical spine, with fusion, without fusion, with navigation, without navigation. These are like the building blocks that you need to know about as a spinal surgeon if you want to be a successful MIS surgeon. And the three technique principles are the understanding that you can achieve a contralateral and a bilateral decompression with a unilateral approach, the understanding that by doing that with minimally invasive surgery, you minimize iatrogenic instability and you can frequently avoid fusion surgery in patients who would probably need a fusion if they had the same operation done with open traditional surgery. And then third is indirect decompression, the fact that you put a cage in, you get indirect decompression and decompression of central and foraminal stenosis. How can you predict that? How can you take advantage of that? Those are all things that you have to know about. The other thing, which is really more technology as well, is navigation. And how can you incorporate navigation, contemporary modern navigation, in order to facilitate your surgery and make it safer. Now, let's talk first about contralateral decompression. So you can perform a bilateral decompression and a contralateral foraminotomy through a unilateral, minimally invasive approach. And this is really the summary. Instead of doing a big open incision and remove a lot of ligaments, a lot of the bone, you get a beautiful decompression, but you're running the risk of having an infection, of causing iatrogenic instability, blood loss, patients stay in the hospital longer. You can do the same decompression through a minimally invasive tubular approach, for example, where you come in a little bit in from the side and undercut and go over the top and get bilateral decompression. We use different types of retractors for this operation. For microdiscectomy, use 14 or 15 millimeter tubes. For laminectomy, 18 millimeter, 21 for TLIF, and then 24 for spinal tumors that we treat also through with this type of technology in the lumbar spine, intradural, extramedullary. This is not relevant. Now, this is a patient that we are treating here for lumbar spinal stenosis at L4-5. I want to just walk through these pictures to demonstrate the basic surgical technique. So this patient has central canal stenosis. We're coming in from the right side with an 18 millimeter tubular retractor, and we're docking over the L4 lamina here, and that's the spinous process. So that's always the starting point. We want to see that conversion between the spinous process and the lamina. And then we start drilling away. I use a matchstick drill, a curved drill. I use a microscope for this. You find the insertion of the ligamentum flavum cranially, or you go between the two leaves of the ligamentum flavum and then open up the spinal canal that way, expose the dura. And then the key here is the contralateral drilling. And that is what a lot of surgeons find challenging initially. The way you do that is you tilt the table away from you and you tilt the tube towards you, and then you undercut the spinous process in the contralateral lamina, and that's how you get contralaterally. If you've done it a few times, it's amazing how natural that approach then really becomes. And then when you work contralateral and you drill the contralateral lamina, you leave the contralateral ligamentum flavum intact, and that protects the dura. That is obviously very important. Hollywood has even made a movie about this. As a joke. So over the top movie with Sylvester Stallone, for those of you who haven't seen it. So so now what you can see here is when you do the over the top decompression, you get a wonderful decompression of the contralateral traversing and also exiting nerve root, almost a better decompression contralateral than ipsilateral. And you have to take that into consideration in your surgical planning when you decide from which side you will attack this particular pathology. We use tubular retractor. There are a lot of different companies that make those. You can use an integrated light source. We use a microscope usually. And then we use bayoneted instruments, Carrison rongeurs, nerve hooks, ball tips, and so forth, tubular retractors here. You can literally do this operation with 5 instruments. In Europe, this is a chapter that was written by Andreas Korger from Munich. In Europe, in Munich especially, they use these specular retractors. In North America, we use the tubular retractors. It doesn't really matter which retractor you use. The important thing is at the end that you get this successful bilateral decompression of severe lumbar spinal stenosis. And people have studied this. There's a lot of class 2, class 3 evidence out there. Essentially what happens if you do this type of surgery, patients go home faster, they have less blood loss, less infection rate, and overall do really well. We can do it in the cervical spine. We now do it routinely in patients who have relatively preserved lordosis and have moderate to severe cervical spinal stenosis. This was an elderly gentleman who had single level severe compression with a myelopathy. I didn't want to do a big laminectomy infusion, so we just did a focal decompression here at C4-5, where he had the worst compression, and we did that through a tubular retractor. In this case, we used navigation because it's nice to see with the navigation that you get all the way contralateral. You can confirm that with navigation, and you can see that here we've got a beautiful over-the-top contralateral decompression of the cervical spinal cord. And that's the intraoperative CT scan that we got just to confirm that we've got a nice bilateral decompression. Also put little facet wedges in at the same time to stabilize that level. And I want to come back to the fact that, if you do these operations, you will realize that you get a wonderful contralateral decompression. And again, this is the key, rotating the table, angling the tubular retractor to get contralateral, over the top decompression. Second technique principle is very similar to the first one. Basically the fact that if you do this through a tubular retractor, you minimize iatrogenic instability, and therefore you can treat a lot of patients where you would usually maybe consider doing a fusion. Now you can avoid the fusion because during your decompression you do not destabilize these patients any further. This is an example is a patient with L4-5 spondylolisthesis and severe lumbar spinal stenosis. The question would be, if you decompress this patient, would you have to fuse that patient? And there's controversy still. Some of the guidelines that were published in the literature recommended for all of these patients a fusion if you do this with open surgery. Now we find with tubular surgery we can avoid a fusion because we leave all those ligaments and all those supportive structures intact. We undercut, we don't remove. So in this particular case also we treated this patient very successfully with a tubular decompression, as you can see here. Now when I look at these patients, for me it is very important to figure out clinically, do they have what I call mechanical back pain? Because the MRI scan is only one piece in the puzzle. This patient may come to the office only with neurogenic claudication and no mechanical back pain. In that case, I will consider a decompression. However, if the patient has the same MRI scan but severe pain leaning forward, backwards, right and left, always low back pain, I would probably do a fusion simply because of the clinical picture of mechanical back pain. Obviously, I will look at flexion extension films, I'll look at the facets as well, but the clinical picture and presentation is, in my opinion, very important. One of our fellows wrote this up a few years ago. He did a meta-analysis looking at papers that compared in patients with grade 1 spondylolisthesis open laminectomy versus MIS laminectomy. And they were looking at patient satisfaction and secondary delayed fusion rates. And what they found was with open laminectomy in these patients, you have about 13% of patients who go on needing a fusion later on versus only 3.3% in those patients who had just a minimally invasive laminectomy. The patient satisfaction was higher with minimally invasive surgery, and so this paper was very well received and won one of the awards at that meeting. So summarizing now, we do MIS decompression instead of fusion now in a lot of patients with lumbar spinal stenosis with stable spondylolisthesis. We do it with a contralateral approach over the top in patients, for example, with a foraminal soft disc herniation, where we come in from the contralateral side and decompress it. We treat patients who have 2-level disease, but only one level needs fusion, like a patient with L4-5 spondy and stenosis, and L3-4 just stenosis. We will do an MIS TLIF at L4-5 and just a tubular decompression at L3-4, for example. And then most synovial cysts, unless they really have instability on flexion extension films, or on patients who have bilateral synovial cysts, would frequently just do a decompression, no fusion. Now, you probably don't see this a lot in Erbil, but maybe a little bit further north. So slalom, and Michael Meyer, who you all know, he wrote a very nice paper about this. What do you do in patients who have multi-level lumbar stenosis? Well, we do the same thing. We just make multiple incisions, and then we go in with a tubular retractor or a specular retractor and decompress the lumbar spinal stenosis. And we do it in a slalom technique to kind of distribute the decompression a little bit better. So we don't do everything from the right or from the left, but we kind of go back and forth. So we make 3 or 4 incisions, and that works very well in these patients. In America, we have too many microscopes. So I use with my fellows or residents, we frequently will do tandem surgery, where if we do 3 or 4 levels, we'll have with the assistant do simultaneous surgery with different microscopes. And that's great for teaching, and it also cuts down on the surgical time because it can become very lengthy if you do 3 or 4 levels. Now, there are a lot of technical details with this tubular decompression surgery. We wrote all that up a few years ago in Journal of Neurosurgery, or Neurosurgery was published, how to use the drill, what type of tubular retractor, how far from the midline do you go, and so forth. And so this was all written up. And this kind of is my introduction into the other T, which was teaching and training. And this becomes so important, especially when you talk about tubular surgery, how to use the drill, how to use navigation, because a lot of surgeons don't have really that experience. Now, some of you have been to Davos, to the AO courses, and we've done training courses there using these synthetic spine models that replicate some of the typical pathology that we see, lumbar spinal stenosis, spondylolisthesis. And I think there was a recent course in Dubai where a lot of your colleagues and yourself maybe had an opportunity to try this out. And this is really a beautiful technology that allows you to use the microscope, to use the drill, to talk to some of the expert surgeons, how to perform this operation. It's very realistic. And you can see here the bone that this colleague is drilling here with irrigation and suction, and the dura, you can get a CSF leak that you can repair. So that's one of the ways that we're trying to really teach this surgical technology. And then as part of the MIS task force that we're working on, just to kind of give you a short overview introduction, we identified a number of basic skills that we're working on, and we're developing educational material for this. And the basic skills, for example, are how to use a microscope, how to use an endoscope, how to use a high-speed burr, how to use navigation. And then on the other hand, we also talk about some of the basic procedures, so where you put everything together. And there are 4 tubular procedures, mainly for decompression. There are 3 endoscopic procedures for discectomy and interlaminar and transforaminal discectomy. And then we're covering 2 instrumentation procedures, which is percutaneous pedicle screws and MIS TLIF for now. And we're expanding that next year to cover translumbar approaches. And we're putting together all this educational material that will then be available at courses such as this one, for you to review and digest and work with, and also practical experiences using these models that we just talked about. Now, going back to surgical technique, there's one technique still missing, and that's the lateral, the Transpsoas surgery. It's great surgery, of course, and I'm sure a lot of you have had some experience doing this. It's really one of the bread and butter procedures now for all of us who do a lot of MIS spinal surgery. And that's because of the indirect decompression and the ability of this operation to help with deformity correction. I want to focus on indirect decompression, which is the third technique principle. It's nothing new. This was described in the 1980s already with ELIF surgery and myelograms here. This was a study out of Asia, but it's been translated now into the lateral approach, the lateral surgery. The idea is you put it in a cage, you get indirect decompression, stretching of the ligaments, and you can treat central stenosis, but you can also treat patients with significant foraminal stenosis, like this patient who had scoliosis and has an L3 nerve root compression here on the concave side. Rather than doing a 10-level fusion, this patient was only symptomatic from an L3 radiculopathy, so we just put in a cage and decompressed that level and just fused that level focally. And that's the idea. You put in a cage, you get indirect decompression here, and that patient goes home the next day frequently. And this is an MRI scan showing the L3 compression here, and that's on the contralateral side. And then we put in a cage, and this patient did very well. I don't do this anymore now with these lateral plates. Biomechanically, they're not very stable. I will always put in pedicle screws now, and you can do that in a single stage operation with navigation or without navigation. But in this case, this is a few years ago. This worked out very well for this patient, and she went home pain-free. Now, we were very interested in indirect decompression, and the problem is with indirect decompression, how can you really predict that it's going to work? Frequently, patients will stage procedures. They will do the lateral approach with the cages, then they'll have the patient walk around and then determine whether they still have to do a direct decompression. I always found that very unsatisfying because it's kind of a trial and error approach, and I think with surgery we should try to know from the very beginning what's going to work and what not. So we did a lot of work on this, and we tried to look at patient factors and procedure factors that determine the success of indirect decompression. So we looked at in our own patients, but we also reviewed the literature. We looked at disc height, central stenosis, facet degeneration, lateral recess stenosis. We looked at the side of the approach, the cage dimension, and cage position, and try to figure out, is there anything that we know before the surgery of these factors that will allow us predict the successful indirect decompression. And we reviewed the literature here and our own case series, and we found that cage height, the type of the cage, positioning, and the side of the approach were not related to radiographic outcome in indirect decompression in these patients. I'm just showing you a few studies. What did make a difference, though, was the width of the cage, and that's something that is obviously makes a lot of sense. The wider the cage, the less the subsidence, and the better the restoration and sustainability of disc height restoration over time. The commercially available cages are 18, 22, 26 millimeters for the most part, and the cages with 26 millimeters reduce subsidence and maintain indirect decompression very successfully. So that makes a big difference in my practice, because now I don't try always to get the tallest cage in, but I will always try to get the widest cage in, which is actually easier to put in, and you're not struggling with the height, and you're minimizing the risk of hurting the end plates above and below. Luis Pimenta and others had a really nice paper about lateral recess stenosis. In patients who have severe lateral recess stenosis, indirect decompression may not work. Okay, so summarizing now, I'm almost at the end of my presentation here, but summarizing, so the patient factors that really, the factors that really make a difference in terms of predicting the success or the failure of indirect decompression is the width of the cage, and which you should try to maximize. And then you should be careful in patients who have symptomatic severe lateral recess stenosis. In those patients, you may also want to consider going in and doing a direct decompression, because just the indirect decompression alone may not really be successful. Now finally, a few words about navigation. I know this is a hot topic. It is financially, it can be expensive. A lot of places don't have the navigation available. We're very lucky. I've been using it for a long time. I think that if you have the availability or if you have access to it, try to make it work. There's a learning curve. You have to be stubborn and you have to kind of stick with it unless you've got some of the most recent technologies which makes it easier. But it's really worth it. We published a paper a few years ago. We found over our almost 15-year experience now, once you get really good at navigation, the nice thing is you can eliminate fluoroscopy, which really improves your workflow, especially for percutaneous pedicle screws. Navigation, it becomes very, very straightforward once you make it work, and once you can make it work with your surgical team and you've got some of the basic technologies available. We use it for localization a lot. It's not even just for putting in pedicle screws, but to localize the correct level. It eliminates wrong level surgery, and it makes decompression much more predictable and easier, and so forth. You don't have to wear lead because there's no fluoroscopy. This is one of the combined intraoperative CT navigation systems that we use. So summarizing, I talked to you a lot about the T's, and again, the most important T is the right patient and right operation, so the target philosophy. I think we could do courses just on that topic, but especially with MIS it becomes so important because you have a targeted approach and you don't have the luxury of treating 10 pathologies at the same time. That's where the diagnostic accuracy really becomes important with MIS surgery. Tools, technologies, we talked about the surgical techniques. That's where the teaching comes in. Going to cadaver courses, going to courses like the AO courses with surgical simulation and so forth, visiting other surgeons, exchanging experiences, teaching and training we talked about, research we talked about a little bit. I showed you a lot of papers that came out of our lab, but really were based on our personal experience, and then we translated that into research that went back and really influenced the way that we think about MIS. Talent is another topic for another course, but it's not, it's also very fascinating. So again, thank you very much. And if you ever want to come to New York, we'll have our 13th MIS navigation endoscopy course in New York in December of 2019. Dress up, it'll be cold again. And thank you for your attention, and thanks for having me in Erbil.